So I'm very pleased to be able to introduce our next speaker. Professor Bruce Biccard is a professor and second chair in the Department of Anaesthesia and Perioperative Medicine at Groote Hospital and the University of Cape Town, South Africa. His research interests include perioperative medicine, perioperative outcomes, and global surgery. He is a proponent of international collaborative research. He collaborates with the African Perioperative Research Group Network, where he has led the African Surgical Outcomes Study, the ACCCOS-2 trial, and co-led the African COVID-19 Critical Care Outcomes Study. He's here today to present the latter study, which has huge relevance for the themes of this conference. Thank you very much, Professor Biccard.
Good morning. Thank you for the opportunity to present ACCCOS to the audience this morning. I'm Bruce Biccard. ACCCOS is the African COVID-19 Critical Care Outcomes Study. These are disclosures. ACCCOS was supported by the Critical Care Society of Southern Africa, and the funding supported the database and the data management of the studies. I have no other conflicts of interest to declare. So what was the motivation for our study? So we knew from previous work with the African Perioperative Research Group that the specialist workforce in Africa is limited. So from the ACCCOS study, we saw that even though the Lancet Commission recommends 20 to 40 specialists per 100,000 for surgery, that we had less than one specialist per 100,000 in Africa. And the result of this limited workforce was failure to rescue, with the mortality twice at the global average following surgery in Africa. And we believe that this failure to rescue, that is complications going on to death, is because we have limited human resources to identify patients who are deteriorating and dying. Now, with that background, we also have built a large network across Africa with the African Perioperative Research Group. And in ACCCOS, we had 247 hospitals, nearly 250. And in ACCCOS-2 in the trial, we had over 300 hospitals participate. So when COVID-19 broke in 2020, we expected that the outcomes in Africa would be worse because we had a limited workforce and we had limited intensive care facilities and critical care resources to provide sufficient care. So from our previous experience in the African Perioperative Research Group, we expected this and we had a network already established to respond to this concern. So at the time, we looked at what the critical care resources might look like in Africa. So we knew in Europe, they were running at about 11 beds per 100,000 population. We estimated in Africa that we were running at about 1 bed per 100,000 population. And then when you look at the nurse to patient ratio, the ideal is 1 nurse to 1 patient. Our data from previous studies suggested that more than 50% of the hospitals that participated had less than 1 nurse per 2 patients in the critical care environment. So what was the methodology of the study? So those study objectives were in patients with suspected or known COVID-19 infection in Africa. We wanted to identify the critical care resources associated with survival. We wanted to identify patient comorbidities and other risk factors associated with in-hospital mortality, and to identify any in-hospital interventions associated with survival. This was a multi-center prospective observational cohort study on adult patients who were admitted to critical care with suspected or known COVID-19. The recruitment was to run from April to December 2020, and we Our sites to continue individual patient recruitment for as long as possible, understanding that we were in the middle of a pandemic, and if a site could not continue, that they would stop recruiting. And the follow-up was until hospital discharge and censored at 30 days. The primary outcome was in hospital mortality in adults who were admitted to critical care or high care with suspected or known COVID-19. And the secondary outcome was to determine the risk factors, that is, resources, comorbidities, and interventions associated with mortality or survival in these patients. So our plan to use the study to help Africa was to do an interim analysis as soon as there were 250 to 300 deaths registered in the study, because we knew at this point that we would be powered for the primary outcome, and then we could share these data with our investigators and the larger African continental group to help them manage their patients. And we thought that in this way that there might be an opportunity for our colleagues across Africa to implement any changes in response to the findings. We captured data on REDCap. The hospitals registered once, and they gave center-specific data on the level of care, number of hospital beds, the number and level of these critical care beds, the type of the hospitals involved, and then also some characteristics about the patient care and human resources. And then we had a one-page CRF for patients, and we had a delayed consent in that patients who couldn't consent at time of admission could be consented later or through the family later on. This is what the CRF looked like. We collected data on comorbidities. We collected physiological data at the time of admission. We collected data on organ support required at admission, the management the patient received, and the outcomes of the patients. So what are the results? So we managed to do the interim analysis, and this was published as a preprint in October 2020. So the data was quickly distributed, and this preprint actually was in the top 10% of all the COVID preprints and downloads. So it was well accessed and read a lot. So I think we achieved the objective of circulating the information from the data. The full study was completed by the end of December 2020 and was published, and here's the QR code. This is what it looked like. So we invited 40 countries to participate. 26 country leaders agreed to participate and contribute to the study. And at the end, only 10 countries could participate and included 64 hospitals. So the first message is, actually, it's extremely difficult to do this research in the middle of a pandemic. So despite the willingness of the leaders, it was difficult for them to participate. And these are what the hospitals look like. So these are predominantly tertiary hospitals that participated, predominantly government funded and university affiliated. If we look at the characteristics of the critical care units which participated, they had a median of 2 specialist intensivists. They had a doctor-to-patient ratio of about 1 to 4. Doctors were on site after hours, 4 out of 5 at 4 out of 5 sites. The nurse-to-patient ratio during the day and night was about 1 to 2. We recruited over 3,000 patients in this period at a mean age of 55, and about 2/3 were male. The important thing to see is their mortality. So the mortality was 48% for the patients admitted to critical care. So essentially 1 in 2 patients admitted to critical care with known or suspected COVID infection died. We conducted a meta-analysis at the time of all the publications on critical care outcomes with COVID-19, and the global average, you'll see, was 32% mortality. So what we knew from the meta-analysis and from the ACCCOS data is that the mortality in Africa is higher than any other region in the world. And in Africa, the excess deaths were between 11 in the best case scenario and 23 excess deaths per 100 admissions when compared to the global average. So these are quite sobering numbers. That doesn't tell the whole story, because when you look at the patients who were referred for critical care, so there were nearly 6,800 referred. And what we see is about half of those referred weren't admitted. So we don't know what happened to these patients, but we suspect that they probably had a poor outcome. The next thing that we see is the critical care resources available were limited. So in particular, if you have a look, so these are areas which are supposed to provide critical care, while only 86% of them could provide pulse oximetry to all the patients. And in about 80% of the sites, could they do blood gases on site? And the more specialist critical care interventions like renal replacement therapy and ECMO were limited. And what we estimated was that the access to interventions required for patients with this level of severity of disease were probably 17 to 14-fold less than what was required, or one would expect for these patients. If we look at associations or with comorbidities with mortality, what we see is mortality increases with increasing age, and it was independently associated with HIV or AIDS, diabetes, chronic liver disease, and chronic kidney disease. If you look at the severity of organ dysfunction at admission, a delay in admission was associated with the increased mortality. An increasing quick SOFA score was associated with increasing mortality. The increasing respiratory support that the patient needed, from high flow CPAP to invasive mechanical ventilation, was associated with increasing mortality. The patient arrested before admission, increased mortality, and the need for vasopressors was also associated with increasing mortality. And the study also confirmed the finding from recovery that patients who had steroid therapy were less likely to die. So from the ACCCOS data, we can actually use the data for simple risk stratification at admission. I'll give you an example. This QR code would take you to an online tool that you could use. So these are the factors which are independently associated with mortality following critical care admission. So here you've got a patient who's 56 years old, who's got a quick SOFA score of 1. So let's say they're tachypneic. They ultimately require ventilation, and they have steroids available. So the predicted mortality for that patient is 39%. If that patient also had diabetes, and let's assume they had 2 quick SOFA score risk factors, so they also became hypertensive, and they had a delay in admission to ICU, the predicted mortality is 70%. And if this patient also then had HIV and there were no steroids available for the treatment of that patient, the mortality would be nearly 90%. So what are the implications of these findings? So what we see is that there's excess critical care mortality in Africa, and this is probably due to limited critical care resources. And really what we need now is we need a strategy to improve outcomes for patients with severe COVID-19 in Africa, and basically with critical care patients. And really what we need is a short-term strategy and a long-term strategy. So from a COVID-19 perspective, the short-term strategy has to be vaccination, because it decreases the severity of the disease and mortality. And this is the data from the 1st February on the number of vaccinations. And you'll see in Africa, it's running at probably between 0 and 80 per 100 people. That means less than one vaccine dose per individual in Africa. And you can see in the high-income countries, they're running at about 200 plus, meaning more than 2 vaccinations per individual. So this is the first thing that has to be prioritized. If you want to look at a long-term strategy, and we need to look at a long-term strategy because we know the resources are limited. This is a great study which is online, early access at the moment, with anesthesia and analgesia. And it was a survey of the critical care resources in Ethiopia. It's extremely enlightening, especially in the light of our findings from ACCCOS, what it actually looks like on the ground across Ethiopia. Tim Baker, Delia Mabedi, Wangari Waweru Siika, and myself were asked to write an editorial on this paper from the survey in Ethiopia. The editorial is unpublished at the moment, but I think these are the principles that from the findings in ACCCOS, from the Ethiopian survey, of how we interpret these findings and what they mean for long-term strategy for critical care in Africa. So the first thing is, it appears that you probably need about 2 to 5 critical care beds per 100 patients, per 100 hospital beds. And the real enlightening thing from the Ethiopian paper is that you can count the critical care beds, but the reality is their distribution is not equal. So you can get numbers which look like this when you look nationally, but the reality is most of critical care beds are placed in certain metropolitan areas. And that means large proportion of populations don't have any access to critical care beds. The next thing is, one can't just count the beds, you need to look at the level of the bed. So if you look at critical care beds from the basic bed, like a level 1 to advanced bed at level 3, what you see in Ethiopia is there are no level 3 beds. In fact, all the beds are level 1, which is essentially equivalent to a high care bed. So it's important to understand the level of the critical care bed that's provided as well. The second thing is, like, why are there such limited critical care resources? And I think there are 2 factors. Well, we thought there were 2 factors. The one is a lack of recognition of the importance of critical care. Yet, when you look at universal health coverage, there are 46 essential interventions, 16 of them require critical care. So it's part of the basic requirements for universal health coverage. The second thing is there's the essential emergency and critical care package. And this is 40 processes and 67 hospital readiness requirements, which are ready to provide essential emergency and critical care, the most basic requirements. And most of the hospitals in Africa actually can't provide these essential factors. The second thing which comes up as, or group that comes up as being extremely important, is funding. It appears that predominantly, for example, in Ethiopia, only 6% of sites had funding which was earmarked for critical care. So this is a problem because the funding goes under other budgets, so it doesn't actually often end up in critical care. So what can we do to improve the quality of critical care? Well, certainly the data suggests that we need DUI initiatives, and these really need to focus on education and processes and protocolize care so that we can provide the essential emergency and critical care packages at all sites. And then we need to focus on resources, because clearly from ACCCOS and from the Ethiopian survey is the resources are really limited, so limited that it's even difficult to provide sufficient level 1 beds. And just as we saw in ASOS, that there was failure to rescue, it's very likely that in a critical care environment, it's exactly the same, because we don't have enough resources to identify the deteriorating patients. So, in conclusion, there's an excess critical care mortality in Africa compared to the global average. This is driven by a lack of resources and a lack of the essential critical care processes and hospital readiness factors needed to provide essential critical care. And so to improve critical care outcomes in Africa, we have to focus on delivering the essential emergency and critical care package, and we have to allocate funds to critical care to increase resources. Thank you.
Thank you very much for your talk there, Bruce. It's great to have you here with us today, and that's really enlightening and so important that this study has happened. We've already got a couple of questions coming through in the chat for you. The first one is, how can we leverage the current crisis to effectively advocate for sustainable and long-term changes to the funding and development of critical care in Africa?
Thanks, Sonia. So I think, firstly, this has provided quite a lot of advocacy. So, understanding, I think the first thing that's really clear is that there's excess deaths in Africa, and that's a very strong and very clear message, and the data is good. And so certainly we can leverage that message. The second thing is we did collect some institutional critical care resource data. And so we've got another project running with UCSF, where we hope to look at that resource data and combine it with the predictors that we saw from the participant data. And that might give us also an understanding of the contribution the facility makes to mortality. So I think that data will be very good to, again, advocate for more resources. I think, the paper I spoke about at the end of the talk from the Ethiopian group is very enlightening. And if you take that and you couple it with the essential emergency and critical care package, that package has just been published last year. And really what we need to do is we need to all push for the institution of that package, because I think really what's happening is what we're seeing is what's been called in Africa a critical care bed is really a level 1 bed, which is more like a high care bed. And that means we don't even have that facility in most of the wards or in areas where we're caring for relatively sick medical and surgical patients. And so we really have to, there are quite a lot of things we have to push hard for now to change this.
Thank you. If anybody has any other questions, please type them out in the chat and we'll read them out. How would you recommend that institutions then use that information and the package that you just mentioned to communicate with administration about the needs in critical care?
So what was interesting for us was when we were asked to write that editorial, is in a lot of the conversation was, I think what's been a real game changer for surgery is that the Lancet Commission made the indicators. for surgery. And now, like in the first talk today with the Zambian ENSO, it's, then you've got leverage with governments and budgets, because it becomes it's assigned into agreement with the governments and the WHO. So, which is basically what the NSOP is trying to institute, that agreement. And I think in the critical care environment, we have to work the same way. We have to try and take this essential emergency and critical care package, and we need to leverage it, at the WHO level, that it becomes a signed resolution, which means then governments have to allocate funding to those components. And the thing is, just like surgery is cross-disciplinary, the same with critical care, it strengthens the whole health system. And that's why we have to push for that.
Thank you very much. And another question perhaps I'll ask about research. We hear quite commonly in our partnership and many others that institutions and departments and professional associations really value research, but they struggle to either get research in their department started or get off of the ground from where they are already because of problems with capacity, or perhaps problems with not yet having structures in place for data collection. So what would you advise departments of anaesthesia or professional societies that really want to expand their research output in a manageable way?
So the first thing is we have so little resources. And so I'm a big advocate on, if you do something, it must be meaningful. And so that means, you've got to provide data that gives a signal and is a robust signal. So we don't want to drive false evidence through small underpowered things and occasionally flick up a signal, and it's actually not a true signal. It's just a type 1 error. So we really have to push to work together on big projects, so that's the number one. And we need to ask a very simple question for one simple answer. The whole time you must go for one simple answer. It really can't be resource heavy. So minimum data set, very small. Anything which is nice to have needs to go. And if we go and, if the money is really tight, invest the money in the infrastructure. So the data, repository and that, and the way to communicate with people, that's most important. And the power of WhatsApp groups and that for communicating messages and helping clinicians, and that is key. And I think the work you've seen from the African Perioperative Research Group has worked on those principles, and it's worked on a common vision and belief on what the group wants to do.
That sounds, it sounds very on point. I've got another question here in the chat. Do organisations and governments need to separate funding from critical care and anaesthesia, given it's not earmarked and often swallowed into existing anaesthesia packages? And I can possibly add to that often surgery and anaesthesia funding is also merged as well.
Yes, I think so, because we've seen it. So you can see it in surgery. So the only reason I'm talking about surgery is because I think it's the same story, but just probably the data is more clear because the Lancet Commission has driven people to produce some of the data. And what happens is, just like surgery offers a part of treating a disease, critical care provides a part of treating diseases. And all the money is put into these silos like non-communicable disease, etc. And part of that is critical care. And because it's not siloed as critical care, the money doesn't reach there. And critical care, I think, is a real problem. Is it's seen as, high, fancy, expensive medicine. But I think the point I tried to make in the talk, the reality for universal healthcare is about a quarter to a third of all procedures. Part of universal healthcare has to have critical care to deliver it. And so, yes, we need to find some way of making sure those funds are earmarked. And in the Ethiopian study, it was really clear. They had 6% of the facilities they surveyed the whole country, which actually had a critical care budget. And that's the problem. The money just doesn't get there.
Thank you very much. Well, it will be good to follow your work and also of other groups as we kind of try to unravel this question a little bit more and move forward with more national strategic plans.